Okay, I think we'll go ahead and get started. First of all, welcome everybody, and thank you for joining us for the first lecture of the 2021 Dean's Lecture Series. Let me begin by asking the best way to watch this, view this, as probably most of you know by now, but put it on speaker view, and you'll get the best experience. I hope the year is off to a great start for everybody. I know there are a number of you who have started hybrid teaching and are just thrilled to be back into the classroom. So thank you for all you're doing to make this term a success. I'm so excited to hear today's speaker, and I'll introduce her in just a moment. But first, I'd like to say a little bit about the significance of earning the rank of professor at the Bloomberg School. This advancement represents an incredible achievement and confirms not only the respect and high regard of the school, but also of colleagues across the nation and indeed throughout the world. The Dean's Lecture Series was designed to introduce the Hopkins community to the work of newly appointed or promoted professors and provide a forum to promote the interchange of interdepartmental awareness and collaboration. And now I'm delighted to introduce our esteemed Dr. Lori Heise. Dr. Heise is a professor in the Department of Population, Family, and Reproductive Health with a joint appointment in the School of Nursing. She has over 30 years of experience working in the areas of gender equity, social change, and women's economic and social empowerment. She's an internationally recognized expert on the causes and consequences of violence against women and was a co-investigator on What Works to Prevent Violence, a 6-year, multi-million-dollar project to reduce gender-based violence in low and middle-income countries. Her current research focuses on preventing violence against women and children in the family, transforming gender norms, and serving as technical director of the Prevention Collaborative, a global initiative designed to support evidence-based prevention strategies on gender-based violence in the Global South. Prior to joining the Bloomberg School, she was a professor at the London School of Hygiene and Tropical Medicine, where she served as research director of STRIVE, a 6-country research collaboration dedicated to studying the structural drivers of HIV, including gender inequalities, stigma and criminalization, lack of livelihood options, and alcohol use and harmful drinking norms. Earlier in her career, she co-founded and directed 2 civil society organizations, one focused on sexual and reproductive health rights, and the other on women's HIV prevention needs. Dr. Heise received her undergraduate degree, magna cum laude, from Brown University, and actually she graduated second in her class. And she also received a PhD in social epidemiology from the London School of Hygiene and Tropical Medicine. She has been recognized with multiple awards, including the Elsevier Atlas Award, showcasing a single article from 2,500 journals with the potential to significantly impact people's lives around the world, and the Omololu Thalobi Memorial Award for Excellence in HIV Prevention and Community Advocacy. She was also recognized by Ms. Magazine as one of 50 women who made a difference. Most recently, she was nominated by her peers to receive the Citizenship Award from the PFRH department. I am delighted to welcome Professor Lori Heise. Lori?
Thank you so much. It's really a joy to be here, and it's not necessarily the easiest circumstances, but I love the fact that I know that many of my colleagues and friends are in the audience. As Dean McKenzie said, I've spent most of my career working on 2 issues, preventing violence against women and their children, and also women's sexual and reproductive health, and especially HIV and the needs that women had for tools that they can use to protect themselves from HIV. And when I sat down to think about this talk, I sort of vacillated between, do I go real in-depth on a particular research project, or do I tell more of a personal story? And I was thinking, well, you know, the opportunity of a dean's lecture is sort of an opportunity for stock taking and some perspective looking at. And so I thought, you know what, I think I'm going to take that route. And I realized when I looked over the course of my career, there's actually a very close sort of alignment between the emergence of violence onto the global health agenda and my own personal career path. And partly that's by design, me pushing that agenda and that agenda pushing me. So what I hope to do today is share with you a little bit of my story and a little bit of that global story, with the idea that I want to talk about the role that evidence-based advocacy can play in important issues and actually translate into benefits into real people's lives. I also want to talk a little bit about what I call sort of the power of paradigms, passion, and persistence. And whenever I'm doing teaching, I always hearken back to the history of things, because I think people who have been involved in trying to create social change, it's really important that we don't forget our history, because it so often gets sort of lost or even rewritten. So I think it's important both for those who have slogged along the way, but also for today's young people who are really thinking about, can they actually see anything changing? Well, maybe not in 1 or 2 years, but when you have the perspective of like 30 years, you start to see how much can change in one person's life. And finally, I just want to talk a little bit about sort of non-traditional career paths. I mean, I am not your classic academic. I came to academia quite late in life. But for those of you who may find yourself on a non-traditional path, I think there's some really important lessons about the value of what I call bridge leaders, of people that can really do that kind of translation between what's emerging in academia and how it gets applied, and then bringing what we're learning through programs and application back into theory building. So people often ask me, well, how did you get involved in this? Especially the focus that I have on low and middle income countries, Africa and Asia and the like. And I think this is also kind of interesting aspect of it, is how issues find you. You don't necessarily always find issues. And when I was very young, my very first job out of college, one of the things that happened was one day I worked in an office, and one thing that happened was there was a big commotion and everything. Couldn't figure out what's going on. It turned out there was a very abusive man who had come into the office, and he was tearing through the office looking for what I realized was his wife, who actually had left home and was staying at a shelter. So the only place that he knew where he could find her was her site of employment. And I realized that this woman was really in danger. And the one thing that saved her that day was that we locked her in the women's bathroom. And so sort of out of that experience, I started volunteering at the local women's shelter, sort of solidarity with my colleague. But it wasn't until later, so in my late 20s or mid 20s, when I first got engaged or exposed to the issue internationally. And at the time, I was trying to go and shift into international development work, and I got offered a position, a research assistant positionship, at a place called World Watch Institute, which is a think tank, a global kind of environmental think tank. And I had already sort of planned to take this, kind of the only thing you can do in your 20s, the mega trip, where you go off and you go to India and you go to Nepal and all of that. And unfortunately, I thought, oh my God, I'm not going to be able to take my trip that I had planned out. And they said, well, actually, you can go as long as you do research on the way for this piece that we're doing on deforestation. And so I took my sort of 20s backpacking trip. And one of the things I did was go into the very northern tip of India that you see on the map there, into what's called the Garwhal Himalayas. And I was on the heels of looking for this women-led environmental movement that was working on reforesting this region of the world. And it was called Chipko because they had used nonviolent social action to try to stop the strip mining that was going and the not strip mining, but kind of the clear cutting of forest that was going on and creating havoc with their water supply and their access to firewood and things. And so I went up and I spent 3 or 4 days with these women at one of what they called their eco-development camps, and they were doing reforestation. And so I talked to them, I had a translator, and we chatted a lot, and I asked this one question, this very open-ended question about, well, if you could change one thing about your life to make it lighter, what would it be? And to be honest, I was kind of fishing for like, oh, I have to go so far to get firewood, and something I could use for the story that I was supposed to be writing. And what shocked me was the number of times that something related to their husbands drinking and being beaten came back as their answer. And so I started asking that question everywhere I went. And I was just struck at how on the tips of tongues of women who had many other challenges, that this is what they were focusing on. And I hadn't really heard anyone in the kind of what was then called the International Women in Development world talk about this issue. So I went back and I worked at World Watch, but then I decided I really, after doing some more research, I really wanted to see, how does this manifest in women's lives when you're not just dipping in for a day or two. So at that point, I joined an organization called Escalapius International. It was a health promoter project, and it was in this beautiful part of Guatemala on Lake Atitlan. It was a real hardship post, I tell you. It was absolutely gorgeous. And I worked training Indigenous women and worked with them, maternal and child health promoters. And one of the things that became really clear, my kind of personal agenda underneath this was just to observe and learn to what extent violence rose up as an issue in these women's lives. And it was constant. It kept women from participating. Women would show up with bruises. It convinced me that we really were missing something important in international health. So this is where sort of a leap of faith comes in, and also a dose of privilege and a grandmother's love. So what I mean by that is I came back home and I really wanted to try to see if I could work on this issue, but there were like no jobs that you could go and get to work on the issue. So I borrowed $10,000, and that was what I thought I needed to work for a year. And I made myself a promise that I would, I'd work trying to work on violence as a health issue. And if after a year I couldn't make a go of it, I'd go get a job. Well, actually, that was the last time I've ever applied for a job, except for here. I started just raising money and continuing to do work on this issue from a bunch of different standpoints. And so I had raised money at this point from some grants to try to start to piece together an evidence base. And at the time, there was literally nothing that you could read about violence and its intersections with sexual and reproductive health. And from this, I learned the power of of borrowing the legitimacy of other organizations. So I did the kind of nuts and bolts, dirty work of putting together things and doing the writing and the research and organizing meetings. But I worked with institutions that could get people in the door. So in 1993, I was involved in organizing the very first, I think probably the first ever global meeting on violence against women and women's reproductive health in collaboration with the Population Council. I also, in 94, wrote this kind of background paper on violence against women as a hidden health burden. And again, it was just like finding things in transcripts and piecing little things together and really trying to articulate the argument. And I think actually I was told once that it was the most cited discussion paper they ever had, although I'm sure most of the World Bank people never even knew they published it. But it was one of the only resources at the time. And then later, I actually collaborated with colleagues here at JHU in the Center for Communications program and wrote one of their kind of archetypal population reports on how violence against women affected family planning and women's sexual and reproductive health. So at this time, we were starting to get little footholds locally and in discussions, but it was still totally absent from the kind of international agenda. And just to give you a sense of how absent it was, is in 1993, the World Health Organization had one of their World Health Days on violence prevention. And the kind of picture we got a hold through some colleagues and allies of ours at WHO of sort of what they were going to do for this Violence Prevention Day. And what we saw was, it was a picture of a globe of a man, and he's standing up like this, and there's like guns and knives coming at his head. And it was like totally male and very masculine, and nothing about violence in the private sphere. So we met with them and sort of, in effect, shamed them into allowing us to organize a meeting on World Health Day about violence against women and children, and kind of elevate it, again, using WHO's imprimatur. The other thing that we did then is, I just want to pull this up, is at the time, there was not the notion of the socio-ecological model, which is second nature now in public health, actually was not as ubiquitous as it was today. And in fact, it had started just to be introduced in health promotion. It originally started from child development. So Uri Bronfenbrenner was a child psychologist and development expert who introduced this idea of nested layers of causality. And when I saw that, I thought, this is a really important way to think about violence, because it's not necessarily deterministic. It's more like a chronic disease where you have the interplay of factors operating at an individual level and relationship level and the like. So in '98, I published an article calling for the field of violence to take on board the socio-ecological model as a useful paradigm. And that was later taken up by WHO and CDC. Later, we also kind of reviewed all the literature about what emerged at different levels as predictive, and reconceptualized it a bit to try to, as you see on the right-hand side of the screen, to not lose the importance of that developmental history of the kind of genetic endowment and epigenetics and the things that happen experiential-wise in trauma and childhood, and how that feeds into violence in adulthood. So at this time, though, it became clear that we were not going to be able to make progress unless we could really get the data that was going to convince people that this was really a profound issue and it existed everywhere. The problem was no one really knew how to do this safely. And I, of course, didn't know. So I was running an NGO then, and we put together something called the International Research Network on Violence Against Women. And we met for 7 years, and we would bring together anyone we could find who had experience and was trying to do this. We would bring to meetings every year, and we'd share notes, and we kept creating a body of knowledge based on people's experience. And it was really important at the time because people were so isolated. So like you see here, this young woman from China, she said, I felt so alone. People didn't want me to be researching wife beating. I can't believe I'm in a room of people who don't think I'm crazy. I also remember hearing that from a Palestinian man who actually got death threats for doing research on this topic. There was also a lot of people who just really didn't recognize some of the safety and ethical issues that it presented. So this was a woman from Mexico, and she says, we were so naive. When we first added questions on violence into our survey on contraceptive use, we didn't do anything special. It never occurred to us that we'd have problems. Later, we found out that 3 women had been severely beaten for participating in our survey, and we felt awful and realized that we were in over our heads. So it was through this experience that we then pulled all that together and published this manual on researching violence against women. And then took those lessons and said, okay, let's actually mount the study that we know needs to be done. And so working with an ally within WHO and colleagues at the London School and my NGO at the time, we set about doing the WHO multi-country study on women's health and domestic violence. And so this was a 10-country, 15-site study, the first time that anyone had ever collected data that was comparable, or we tried to make it as comparable as possible by using collectively developing the instruments. We worked with teams so that there were teams of women's organizations and local researchers. It was really quite interesting. We had a very different style than WHO was used to. But out of this, we got the first really strong, unindictable data that showed how ubiquitous this problem was. So just for those who aren't familiar, what was covered in this, there was a lot of focus on intimate partner violence, but also included violence, physical violence by others and sexual violence by others in adulthood and sexual abuse in childhood. And the way we measured this was actually behaviorally. So you ask specific questions so that people don't have to actually say, yes, I was raped, or no, I wasn't raped. You ask, did specific things happen? And that you lose nuance, obviously, of how people interpret those events. But if you're actually trying to do comparative, it's the best way we have that we have available in order to try to get comparable quantitative data. So what we learned in this is that something that feminists had said for a long time. Excuse me, I'm just going to close this. Something that feminists had said for a long time is that turned out to be true across all of these settings, which is that women were more likely to be physically beaten or raped by their partners than anyone else. And what this, if you look at this graph, it really is the black is the proportion of women in each site that were abused by their partner only. The light blue is both a partner and somebody else. And the dark blue was abused by non-partners or only by non-partners. The other thing that came through really clearly was how dominant interpersonal or intimate partner violence is in the overall life burden of violence for women. So what you see in this is a proportional Venn diagram, meaning that the size, right, represents how common something was. And it was all 24,000 women who we interviewed as part of this study. And the orange, the two oranges are physical and sexual violence by partners. The little green at the bottom is child sexual abuse before 15, and the blue is sexual assault after 15. And then the overlap is the women who experience both. And what we have learned and has been confirmed over and over again in other studies is that even in settings of conflict where people are concerned about sexual violence by combatants and things, the dominant form or the most common form of violence that women experience is from intimate partners. So this is just give you a sense of some of the data that came out on prevalence of physical or sexual partner violence in the past 12 months. And I think the important thing about this slide is that we do see significant differences in average levels across settings. So anything from, this is Ethiopia province, which is Butangera province, 53.7% of women reported being physically or sexually abused by a partner in the last year, versus in Montenegro, Belgrade, Serbia City, or the city in Japan is about 3.7. And that's not that different than what you see of the kind of classic difference between high income settings and countries and lower income countries. It's always in, Australia, Europe, the US, Canada. About 3% of women in any year are physically or sexually abused by an intimate partner, whereas in many other parts of the world, it's an order of magnitude higher. Now, more important than that, though, is that that level of variation also exists within every country. So this is just, I pulled this up out of the Afghanistan DHS, and it just shows you that these are different provinces in Afghanistan. And so some of the provinces have less than 6% of women who report being abused, and some have 76 to 92%. And so you see an enormous amount of variation within countries. And then if you go down to the level of even cities, you see that variation. Now, this is a slightly different graph. This is the percent of women in the cluster, or if you can think of it sort of as the neighborhood, who report partner violence. So this is Brazil City, which is São Paulo. And so in 6.5% of the neighborhoods, none of the women reported any violence in the last 12 months. Whereas in 23% over here, 50 to 59% report violence. Now, if you go to the rural province of Pernambuco, which is where we also did the study, you see that a similar sort of almost normal curve, but it's shifted to the right. So here you have far fewer clusters with no women who are abused, and some where even more than 70% of women report abuse. And so this speaks to the whole importance of thinking about violence at a population level, because if those who have remember the kind of classic epidemiological article by Rose about how what you really want to do is you want to shift these curves. So in a perfect world, what we'd want to see is the whole curve shifted to the left, so that yes, you would have some violence, but the average would be much lower. And I think this is what you see much more commonly in high income countries. So the other thing that came out of this, which I think shocked a lot of people, was just how normative violence was in these settings. So just to give you an example here, there's a question that is also now in the demographic and health surveys that says, do you think a man is justified in beating his wife if, and then it gives a number of different options, like if she disobeys him, if she refuses him sex, if she doesn't take care of the children. And what you see is people actually make finely grained distinctions based on what the mistake or the issue is. So in Ethiopia, 78% say, yes, it's okay. And these are women now responding. It's okay for him to beat me if I disobey. Less concordance around if she refuses sex. But in a place like the Pernambuco in Brazil, only 10.9% agree that it's okay, of women agree that it's okay to be beaten if you disobey. And what this goes to is there's a very common logic that you see over and over again in Africa and Asia, which is that beating is actually framed as a form of discipline. And so, like this woman in Mexico says, well, I think that if a wife is guilty, meaning she's actually done something wrong, the husband has a right to hit her. If I've done something wrong, nobody should defend me. But if I haven't done something wrong, then I have a right to be defended. Here in Tamil Nadu, you see, if it's a great mistake, then the husband is justified in beating his wife. Why not? A cow will not be obedient without beatings. And you can find, I could pick up any transcript in any place I've ever worked, and you see this same logic. And what it is it's almost like in each setting, there's what I call the line of acceptability. And it varies. It's a nexus between how severe the beating or the event is. For what reason? Is it considered a valid reason, or is it considered arbitrary? and then the social positioning of the two people. So it may be okay for a husband to hit his wife, but not for a husband to hit his employer. Or it might be acceptable if he hits, but not too hard. But if he lands her in the hospital, that other people will intervene. So again, part of the task is to shift that line of acceptability and create a new social norm. So another thing that came out of this work with WHO was the first set of ethical guidelines for safety and ethics of conducting research on domestic violence and other types of violence in the developing world. And here, it's a little hard to see, but it was things like, only interviewing one woman per household so that the other women or men in the household might not know or wouldn't necessarily know that she was being asked these questions. Doing complete privacy, doing specialized training for interviewers, really prioritizing the safety and the emotional support to the field staff, who oftentimes suffered vicarious trauma. And so there've been a variety of different renditions of this, but it still is sort of the foundational a document that is used for thinking about ethics around conducting this type of research. So one of the things, though, is the WHO study was sort of a once-off thing, and we really wanted to figure out a way to decide whether it was possible to, for example, get the DHS, the Demographic and Health Surveys, to take up the task of doing this research on an ongoing way, so that we could develop a better database. At the same time, we were concerned because we knew about what was actually required, both to get good data as well as to keep women safe. So at the time, what we did is we went to Swedish SIDA and we got funding to develop a module for the DHS. And we negotiated with the DHS to pilot it in Nicaragua, and we worked with the ministry there. And we said, here are the guidelines, and these are the accommodations that need to be done in order to do this well. And they include things like the one woman per household. And at the time, the DHS they interview all the women in the household. So we thought that we had that agreement, but it turned out in the end that we didn't. And so they went forward with the module, but they didn't put in place all of the things that we felt were important for getting good data and keeping women safe. So we went back to Swedish SIDA and said, can you give us some funding to do over the top of, in a couple places, the same sampling frame, our full technique, and let's see if there's a difference in disclosure, and we will interview the field staff from DHS to see what it was like for them not to have these supports in place. And so what you see here on the left is the two DHSs are both in Lyon, which is on the coast, and then Managua are much lower than the same than when it was done with all of the extra training and the support. So it really does affect data quality. And when you dig into that data, what you see is that what's underreported is current severe violence. And that in the DHS, when there wasn't this kind of rule about not interviewing in front of others, 35% of interviews had other people present, and that there was statistically significant less violence when the husband or two or more others were present. When we interviewed the field staff, we got this kind of information. When I heard stories about women being beaten and tied up, I would leave them feeling desperate. I'd be a wreck. And I'd go to my supervisor, who would tell me, get a hold of yourself. You cry about every little thing. But how could I control myself? I couldn't stand it. I would try, but sometimes it was impossible. And I would burst into tears during the next interview. So taking both the qualitative and the quantitative back to macro, DHS, and USAID, we got them to commit. And now that DHS is done with all of those controls in place, and there are almost 100 countries that have population-based data at this point. So the next thing I just wanted to touch on is what I call the power of paradigms. And this is the idea about shaping of mental models and how it can affect how you think about an issue. And what happened was in 2000, I think it was 2000, I can't see it on my screen. I think it was 2002, 2000. So in 2000, what we saw was the creation of a new department for injury and violence prevention at the WHO. And at the time, they were going to issue what they called a flagship report on violence, the health implications of violence, the global report on violence and health. And when we got a hold of the early outline of the report, it was using as its paradigm this injury prevention model, which is unintentional injuries being like accidents and poisonings and falls and burns, and then intentional being violence, and breaking it by self-directed and other-directed. And so the only information that was going to be included in this was going to be suicide, homicide, and assault data. And not a single person on the that was being invited to do chapters was a woman. So again, we met with them and said, look, if you want to do a report on injury, that's fine. But don't call it global violence and health and exclude all these other health consequences of violence and exclude all kinds of violence in the private sphere. And because of that, we actually got involved in writing the report. And they adopted this revised paradigm, which, as you can see, talks about physical, sexual, psychological deprivation. It then breaks up violence into self-inflicted, interpersonal, so you have family and partner against the child, the partner or elder, and then you have community and collective. And this then set the foundation for the entire work that department has done over the last 15 or so years. And this is so the whole set of questions and who's part of the discussion is changing simply because of changing the paradigm from which they were working. So this just gives you a little example of all of the health consequences of intimate partner violence and the different mechanisms and pathways through which it does influence both disability and death. And one of the things that we also were trying to do was in 2000 or mid-2000s, the global burden of disease exercise was being redone to look at risk factors. And we were very interested in trying to get victimization and trauma as recognized as one of the risk factors that contributed to loss of life or premature death, as well as disability. And we weren't able to get funding from the initiative to actually do the analysis. But at the time when I was at the London School, and we decided that it was such an important advocacy opportunity that we used our core support and did all of the modeling and the systematic reviews and everything to generate the estimate for intimate partner violence and child sexual abuse. And while it didn't actually it made it into the report as a sort of box, but we were able to then publish it in Science, and we co-published it with WHO. And so what you see here is this is now global, but about 42% of women who experience IPV have some sort of physical injury. That's actually not the biggest health consequences. The biggest health consequences tend to be related to mental health and sexual and reproductive health. So mental health, women are twice as likely to experience depression. They're 4.5 times more likely to attempt suicide, 16% more likely to have a low birth weight infant, which influences child health and the like as well, and 1.5 times as likely to acquire HIV. So just around now, I took a little 12-year side trip into HIV. And ran an organization and a campaign to try to raise money and get attention to the need for women to have some method to protect themselves from HIV that wasn't dependent on negotiating condom use. And that was its own thing. It's a whole nother Dean's lecture. But just to say, I think what that helped create, along with many, many, many other people who were doing this work, is that we now have both a pill, a vaginal ring, and just recently an injection that women can take that will actually prevent HIV acquisition. So again, something which was not on the agenda at all, and through grassroots organizing all the way up to raising, mobilizing money and helping, monitor the trials, I think we really made an impact in that area. Just one thing I want to talk about is sort of the importance of retooling. So I went back to graduate school and got my PhD at 51. And it was after I had this 12 years of doing HIV work, I kind of thought I wanted to get back into the violence work. And I felt like, in the meantime, what had happened is we had made the case, we had won, in terms of being on the political agenda, we didn't know what to tell people to do. And that what we had been doing clearly had not been working. So I decided that I had hit a wall and I had to go back and retool. And so at the time I went and I used the data from the WHO study to really look at the determinants of partner violence at its spatial distribution. So that thing that we were looking at earlier about why is it that in some areas there's lots of violence and in some there's not. I mean, and what can we learn about that that will help us with future interventions? I realize I'm going a little long, and so I'm going to skip this. For people who are interested, this is a whole analysis of some of those geographic factors and how they relate to women's status and discriminatory laws and policies as it relates to women's risk of violence. But just to then say, what we did get involved in is this large initiative to really try to start to evaluate different interventions. And so Dee McKenzie mentioned this, What Works to Prevent Violence. It was funded by DFID, which has now been renamed. But it was a large 25 million pound program to evaluate 15 different interventions across the socio-ecological model. And it included actually, one of the things that was funded through this was the work that Laura Murray from the school has been doing on using CETA, which is a mental health intervention led by lay people to reduce violence and harmful alcohol use in Zambia. The one that I was the PI on was an intervention called Indashyikirwa. And it was a violence prevention intervention in rural Rwanda. And it was built around a couples intervention. So it was a participatory training with couples, 21 sessions. The couples were recruited from Village Savings and Loan. So they were very oftentimes the poorest members of their community. And then after the couples would go through this, a subset went on and got additional training in community mobilization, and try to diffuse the messages out into the wider community. In addition, there was the creation of what was called safe spaces, physical places that women could go, and again, trained local community women would offer support. And there was engagement of opinion leaders. And one of the things that we did is we did a really in-depth evaluation that included both following the couples forward in time, quantitatively, doing community surveys at the beginning and the end to look at diffusion. We also did a lot of qualitative work. So we did a longitudinal qualitative interviews with couples over time, as well as a process evaluation where we observed and talked to the facilitators and all of the people to see how well it was being implemented and what went well and what didn't go well. And then there was a separate costing study. And the thing that I think was really interesting is that there was a really big impact of this 21 session couples curriculum. So this is just some of the top line results. So in terms of IPV at 24 months, so it took about 5 months to implement. So at 2 years, we saw a 55% reduction in the odds of women experiencing IPV, similar reduction in symptoms of depression, reduction in child witnessing of violence, which goes to the issue of the continuity of violence across generations. And then also things that you would expect, improved couple communication, more trust and care, and the like. So that was quite effective. The community activism level was not, but fortunately, I mean, it was a flat trial result, but because we had done this process evaluation, we were able to very definitively say that it was an issue of implementation, and poor implementation and delays, and not so much that the intervention itself didn't work, because it had worked in other places. So that was just sort of the importance of doing the qualitative and the accompaniment work so that we know what the results mean at the end. So I'm going to just skip ahead to say that there's just been enormous growth in the evaluation of these types of programs and interventions. We actually have more than 100 impact evaluations of IPV prevention programs in the Global South, and most are controlled. And there's also then these many standalone qualitative studies. So on this graph, what you see is from 2000 up to 2019, just an explosion. And we've learned, I think, quite a bit. I haven't begun to touch on everything that I think I have learned in my detour to retool. But now I feel like the research is out ahead of the programming. And so what's happening is that we know a lot of things that actually, when you visit people who are doing programs on the ground, are not being acted on. And so once again, I'm sort of retooling and really wanting to take research back to practice, because the divide between what we know through research and what is actually happening in programming is getting ever wider. And that's why partly what I'm working on now with my other hat is this Prevention Collaborative, which, as Dean McKenzie said, is this global network of practitioners, activists, and researchers. And we're really trying to equip ourselves and other people to do prevention work through long-term accompaniment of organizations, curating evidence, and ensuring that the donor funding is channeled wisely. And I think I leave that, this is where my story is. And in my role in what I've really enjoyed about academia and being at Hopkins is the ability to pass on and mentor the next generation of researchers. And so I just am really pleased of being able to have landed in a place where I can do both the application and the deep thinking, and hopefully contribute in some small way to make the world a little bit safer for everyone. Thanks.
Well, thanks so much, Lori. That was absolutely fantastic. We don't very often take the time to hear and listen to others' journeys, the stories of their journeys, and it's so instructive. And I hope there were a bunch of students in the audience, especially. We're all students, of course, throughout our entire lives, but there are so many pearls in the talk that you gave, so we really appreciate it. We do have a couple of questions in the chat, and I would encourage people to go ahead and put more comments or questions in the chat as we move along. But the first one is from Lori Roleri, if I've got the pronunciation correctly, another Lori. It says, curious why we don't also look at how physical violence, not necessarily sexual violence, during childhood affects women. What are your thoughts?
So I think it does affect women. It's intriguing because I think people do it, but what has happened internationally is that there's only the question in these surveys on sexual abuse for women and physical abuse and for men, which is a real oversight. But it's so I think that we've been trying to get that to change the next round of the DHS so that, and not just violence, because I think what we really need to be looking at is that whole range of adverse events in childhood. You know, violence is one of them, but we may be focusing on the violence and it may actually be just the general family dysfunction or other elements, and the violence is the marker. Okay. So I do think we need to go broader. It's like, how do you find the real estate in something like the DHS to add questions is the problem. Yeah,
very good. We do have a comment from Caleb Alexander, and in part you've addressed it, and there's a little bit in the chat, but I don't know if you know Caleb from the Department of Epidemiology, and he said it's fascinating talk, but way out of his field. And I wondered about the interaction between substance use disorders and violence. You made an earlier comment about men drinking and being violent, and I wondered how often these commingle, and how much violence prevention has to include or focus to a large extent on substance use disorders like alcoholism.
Yeah, so I think that what you see is there's nowhere in the world where there's not a strong link between especially binge drinking and frequency and severity of violence. I think there's an ongoing debate around, is it causal or is it a trigger? Personally, my reading of the literature is no one thing causes it. It is an important, causes violence. And that when you throw alcohol into the mix, you are going to get a much higher likelihood of violent events and more severe violent events. So I actually think we should be doing more on it. It's quite controversial in the women's movement because people are afraid that if you talk too much about alcohol, people will say, oh, he was just drinking, or it's just the alcohol, and not take it seriously. Mm-hmm. I have been arguing with my peers and colleagues that if we're going to take women seriously, and this is what they say about their reality, and we see it in the epidemiology, we can't just shy away because it's politically difficult. We need to take it on board. But that's why we don't see as much of it as there should be.
Yeah, interesting. And a question from Myra. She says, always great to hear you talk, Lori. Given that the last WHO population-based study was done almost 20 years ago, do you know if and when WHO may do another multi-country study?
So actually it's continued. So there have been, it's not been so much WHO, but UNFPA has redone using the same methodology or a slightly improved methodology in Asia and the Pacific. So and it's been done in China, it's been done in Turkey. So it's being done piecemeal, but it's always using the same set of questions and the same training and things. So I just happen to be using the original, but there are probably, in addition to the DHS, there's probably another 20 countries that have replicated the WHO study.
Yeah. And there's a comment from David Celentano, and he points to the wide variation that we see around the world, and you pointed to that as well. Let's see, there may be one more. Just a lot of, you should read the comments, very laudatory, and everybody was thrilled to hear your talk. Let me just take the prerogative here and just ask you one last question. Oh, wait a minute. Bob Blum is, okay, he says, we do not know whether boys or girls mean what they mean by sexual violence. What is known about boys and men's victimization?
Yeah, so, I think that, the rates of victimization of boys, especially sexual victimization, is much higher than, it's lower than girls, but higher than most people realize. And I think that it has been underattended, partly because of most of the energy around these issues came from women's movement stuff and they focused on girls. I think that there's now more and more recognition that boys are also at risk. And in fact, if you look at the data, the consequences in terms of behavioral consequences and trauma and things are not that different depending on boys and girls. It's the nature of the event, not so much the sex of the victim. So I do think, we need to do more work there.
Sure. So let me just round this out by a question. And actually, Michelle Decker, her comment leads into my question. She says, incredible work and leadership at the interface of advocacy and research. Congrats. I was intrigued by, one of your early bullet points about the value of bridge leaders who span the worlds of research, advocacy, and practice. And you are clearly one of those bridge leaders. I love that term. And I was wondering if you could just talk a little bit about the difficulties in doing that kind of work. And also, you've been here at the School of Public Health for a couple of years now. And as you know, in our strategic plan, we raised advocacy as one of our 5 pillars. And we're really trying hard to do more of that bridge work. And I'd love to hear your thoughts about what we as a school could be doing more to support that bridge work, if you will.
Yeah, I really do think it's incredibly important. I think the hardest thing about it is actually emotional. And what I mean by that is, I think you can learn the different worlds, right? But when you have one foot in multiple worlds, you're never quite solidly in either. And so you're always subject to being criticized from not being hard enough science or being a sellout if you're, and so just sitting with the fact, you just have to really believe in the importance of the role, because it's much easier to find your tribe, right? And be with your tribe and just kind of hold yourself to that one set of standards. But I talk about being, I'm very promiscuous in my disciplinary perspective too. So I do economics and pull from this and pull from that. And I actually think one of the strongest advantages I have is I wasn't trained in a discipline young. So I had that permission, or maybe I just took it or whatever. But it is hard because you are always sort of having to do that translator function. And in the same way that translating constantly is exhausting, I think being a bridge leader can be exhausting. So you have to really recognize the importance of it, which is partly why I decided to do the talk this way today, because I do think when you see it laid out, you can sort of see how it can work, but the day-to-day can sometimes be hard.
Yeah. very frustrating sometimes. Yeah. Well, that's great. I think we'll have to get you back here and just have a whole session on.
Yeah, no, it would be great.
Yeah, this is such an important topic.
Yeah.
So I want to thank everybody. Well, first of all, thank Lori and congratulate her. And we're just thrilled that you're here at Hopkins and part of the Hopkins and the School of Public Health family. You add so much, to what we're doing at the school and in public health more broadly. And also thank you to all of you who've joined this Dean's Lecture. I wish I could all invite you all to the Wall of Wonder for a reception where we could mingle and talk to Lori. But unfortunately, we can't do that. Well, maybe we'll have to postpone it and do it another time. But again, thanks to everybody for being here, and thanks especially to Lori. And have a great evening. Be safe, and we'll talk soon.
Take care.
All right. Take care, everybody. Bye-bye.